Hello future doctors, how are you all? Welcome back to MedSteps YouTube channel. So in this video, we are going to discuss very high yield topic and very important in every patient we are doing this test. We call CBC. So complete blood count. So in this video, we will learn how to interpret a complete blood count in a very simple way. Actually, many clinical students memorize the CBC values but struggle to understand what they actually mean. But by the end of this section, you will able to understand all CBC parameters, identify anemia patterns and recognize infection patterns and interpret platelets abnormalities and correlate CBC findings clinically. So without time waste, let's begin. So what is CBC? CBC stands for complete blood count. Is a blood test that measures like red blood cells and white blood cells and platelets. Okay, so think of CBC as a report card of your blood. So we have some components of that CBC, like first one, red blood cells. The red blood cells, the main function you can see here, it will carry oxygen to tissues, and main protein will be like you can see hemoglobin. Next you can see that is white blood cells. The white blood cells, next you can see that is white blood cells. The white blood cells main function is to fight infections, to protect body from against microorganisms and body defense army. So next you can see that is platelets. In these platelets you can see here the main function is to help to stop bleeding, and it's responsible for clot formation. Okay, so this CBC collection, whenever you are collecting anything like CBC, we have to use purple top. Which one you have to use? If you're collecting CBC, you have to use purple top tube. Why we have to use purple top tube means it contains EDTA anticoagulant. EDTA anticoagulant means it's one type of anticoagulant to prevent clotting, and in sample should be mixed properly and analyzed with a few hours, and poor handling can alter results. So that's why it's important. Okay, so we can see here that is whole blood will collected by that purple tube and EDTA anticoagulant, and we have to do properly. We have to mixing like 8 to 10 inversions. Then we can analyze that thing 6 to 8 hours. If delay may alter results. Okay, so these are the things. Now you can see here components of blood. You can see here that is components of blood. In components of blood, you can see plasma and buffy coat, WBC and platelets. Then after you can see that is RBC. Okay, so here the plasma will be like we can see 55%, and the buffy coat we can see like minus 1%, and the buffy coat means we can see that WBC and platelets. Okay, so next we can see here RBC, that is 45%. So RBC also known as erythrocytes, and WBC also known as leukocytes, and platelets also known as thrombocytes. Okay, so these are things very important. So next you can see here the RBC parameters. So what are the things you can see in RBC? So here in RBC parameters, it will help us to diagnose anemia. So first one you can see that is hemoglobin. Hemoglobin normal values will be like male will be like 13.5 to 17.5 grams per deciliter we can see, and the female will be like 120 to 15.5 grams per deciliter in females. The main function, it carries oxygen. So how we can interpret this with the hemoglobin means normally if patient have low hemoglobin, we have to tell the patient have anemia. If more high hemoglobin, we have to tell the patient have polycythemia or dehydration. We have to suspect. Okay, so next we can see that is RBC count. In RBC count, it measures the number of red blood cells, like how many number of red blood cells, and the male we can see that is 4.5 to 5.9 million, and the female we can see 4.1 to 5.1. And it's like we already discussed before, it measures the number of red blood cells, and while doing interpretation, if it's low, the red RBC is low, then we have to suspect patient have anemia. Same to same like hemoglobin, if it increased, we have to suspect polycythemia. Next we have that is hematocrit. Hematocrit, also known as hematocrit, also known as PCV. PCV means packed cell volume. Here we can see like percentage of blood occupied by red blood cells, and normal value you can see that is male you can say 41 to 53%, female will be like 36 to 46%. So we can interpret it based on if it's hematocrit is reducing, we have to suspect anemia. If it's increasing, we have to suspect patient have dehydration. Next one, mean corpuscle volume. This mean corpuscle volume will tell us like how big are the red blood cells. Like normal red blood cells we can see 80 to 100. Okay, so here in interpretation, if less than 80 means, if it's less than 80 means, we have to tell the patient have microcytic anemia, like small red blood cells. That means the patient have, that means if it's less means the patient have iron deficiency anemia and thalassemia. Okay, if the MCV is more, like more than 100, then patient have normocytic anemia. In normocytic anemia, you can see acute blood loss along with that hemolysis. Next, chronic diseases. So that is normocytic anemia, like around 80 to 100. If it's more than 100 means we have to suspect the patient have macrocytic anemia. Okay, so this is normal. So next we can see MCV will be like more than 100 means we have to suspect patient have macrocytic anemia. The main causes will be like vitamin B12 deficiency and folate deficiency and alcoholism and liver diseases. So these are the main things we can see in MCV. Okay, so less than 80 microcytic, 80 to 100 normocytic, more than 100 that is we call macrocytic anemia. Okay, so in macrocytic anemia, alcoholism, liver disease, folate deficiency and vitamin B12 deficiency we can see. Next we can always remember, if you want I will give a mnemonic. If the cell is normal, the blood loss problems. If cell is small, iron related problems. If the cell is large, the B12 or B9 deficiency. Next you can see here that is MCH. MCH means mean corpuscular hemoglobin. So this mean corpuscular hemoglobin measures amount of hemoglobin inside each red blood cell. Okay, the normal value you can see that is 27 to 33 pg. Okay, and next we can see that is MCHC means mean corpuscular hemoglobin concentration. It measures concentration of hemoglobin in red blood cells. The normal we can see 32 to 36 grams per deciliter. So how we can interpret this thing means, if low mean corpuscular hemoglobin concentration means we have to suspect hypochromic cells. If hypochromic cells if you are seeing means the patient have iron deficiency anemia. So normally we will see this thing with the MCV and RCDW. If we don't have this properly, if it's not telling, then we have to go with MCHC. If it's low means we have to suspect patient have iron deficiency anemia. Okay, next we have another one that is RDW. RDW means red cell distribution width. So it measures variation in RBC size. Okay, so normal we can see that is 11.5 to 14.5. So in interpretation point of view, if that RCDW or RDW increased, that means the different sized RBCs are there. So mostly we can see the different sizes sized of RBC in iron deficiency anemia and mixed anemia. Okay, so whenever you are seeing any X-ray, whenever you are seeing any CBC complete blood count report, that time we have to follow one shortcut. Always first we have to look at hemoglobin. If that hemoglobin is low, then that means we have to suspect patient have anemia. Then after we have to find out what type of anemia patient have. Then we have to go with MCV. We have to check that MCV. If that MCV is reduced, then we have to suspect patient have microcytic anemia. If that MCV is normal, normocytic anemia. If MCV is more, macrocytic anemia. Then after we have to look at RDW. If that RDW is increased, we have to suspect patient have iron deficiency like anemia. For example, I will give one report like hemoglobin 8 grams per deciliter and MCV equal to 70 and RDW equal to high. Then the diagnosis will be like iron deficiency anemia. So next we can see here that is some WBC parameters like white blood cells indices. This is the main white blood cells will fight against infections. So here we can see some total leukocyte count. So total leukocyte count means normal WBC, that is 4,000 to 11,000. Okay, how to interpret it? If high total leukocyte count means high WBC means the patient have leukocytosis. That means patient have infection or inflammation or leukemia. So these are the three things we have to suspect in high total leukocyte count. So next we can see low TLC means low total leukocyte count means we have to suspect leukopenia. The main causes will be like viral infection, dengue and bone marrow suppression. If patient have viral infection, dengue and bone marrow suppression, we have to suspect patient have leukopenia. Next we can see some differential WBC count. Okay, so this WBC count will tell us which type of WBC is elevated. So we have some different types of WBCs. So first one we can see that is neutrophils, very important. This neutrophils, the normal value 40 to 70%. The main function will be like it will fight against the bacteria. Okay, next if it's more high like the neutrophils is the main first line defense against bacterial infection. If high neutrophils means we have to think bacterial infection. Examples like pneumonia, patient getting any symptoms like appendicitis or sepsis. Okay, so it's related to infection. Next we can see that is lymphocytes. In lymphocytes we can see the normal range will be like 20 to 40. If this is the main lymphocytes will fight against viruses, immunity, antibody production and viral defense. So if it's high lymphocytes, we have to think viral infection. Example like COVID, mononucleosis and viral fever. Okay, so next we can see that is monocytes. Monocytes is normal like around 2 to 8%. The main function is to clean up cells or chronic inflammation or phagocytosis. Clean up cells means like macrophages will eat the bacteria will consumption, so we call that process the phagocytosis. And if patient have any chronic inflammation, the monocytes will increase. Okay, if high monocytes means we have to suspect patient have tuberculosis or autoimmune disease or chronic infection. Next we can see that is eosinophils. Eosinophils is the normal around 1 to 6%. The main function we can see if any patient have any allergic reactions or parasites, that eosinophils will increase. So the high eosinophils we have to think allergy and parasites and asthma. Next you can see that is basophils. The basophils is normal 0 to 1%. The main function is we can see like allergy and inflammation, and we can see some mediator release. Like the main function is the basophils will release histamine. High basophils means we have to think myeloproliferative disorders and allergic conditions. Okay, next. So if it's okay, in simple point of view, if you're seeing neutrophils, we have to suspect bacterial infection. If it's lymphocytes, we have to suspect virus and virus related things. If it's monocytes, chronic infection. If it's like eosinophils, allergies and parasites. If it's basophils, the patient have some bone marrow disorders or allergic inflammation or mediator release. Okay, so next, at last, we can see that is platelets parameters. In platelets parameters, first one very important, that is platelet count, means number of platelets, how much we have. So in normal case, normal range, we can see 1,50,000 to 4,50,000. So we can see some low platelets. Low platelets means we can call that is thrombocytopenia. This thrombocytopenia we can see in three different causes. One is dengue and ITP. Okay, ITP, then after bone marrow failure. Okay, next we can see that is high platelets. High platelets we can see in thrombocytosis, like infection, inflammation, then after iron deficiency. Okay, next we can see that is we call MPV, mean platelet volume. In mean platelet volume, the mean platelet volume will measure platelet size, average size of the platelets. The normal level we can see that is 7.5 to 11.5. So the MPV, the mean platelet volume is high, means we have to suspect large young platelets and bone marrow actively producing platelets. And next we can say that is MPV, like low MPV, mean platelet volume, it reduce platelet production. Okay, next we can see here that is PDW, means platelet distribution. This platelet distribution we can see in the platelet distribution, we can see like around 9.0 to 17.0. The platelet, it will help to find out the variation in size of platelets. Next we can see that is PCT, platelet crit, 0.15 to 0.36 percentage for finding the total platelet mass in blood. Okay, next, how to interpret these platelets. If you are seeing here, if increased platelet count means, that means the patient have some reactive infections like inflammation or iron deficiency and like myeloproliferative disorders. Okay, next we can see here that is reduced platelet count means the patient have dengue or idiopathic thrombocytic purpura and drug induced and bone marrow failure and disseminated intravascular coagulopathy. If increased MPV means it's like increased platelet production and destruction and recovery. Next, reduced MPV means it's related to decreased platelet production. Okay, so these are the things. Next, here you can see that is MCV and MCHC interpretation. Whenever that MCV is low, whenever the MCV is low, then we have to suspect patient MCV is low and the MCHC is more, then we have to suspect patient have microcytic hypochromic pattern, that means iron deficiency anemia and thalassemia. If MCV is low, like microcytic, along with that the MCHC is normal, we have to suspect same to same microcytic but normochromic, like iron, like early iron deficiency anemia and anemia of chronic disease. If MCV is normal and MCHC normal, normocytic, normochromic means acute blood loss or hemolytic anemia or anemia of chronic disease. If MCV is more and normal or increased of MCHC, that means macrocytic hypochromic pattern, that is like you can see some causes B12 and B9 deficiency and liver disease and alcoholism. Okay, so in interpretation of WBC, the neutrophils means bacterial infection, stress and inflammation. If it's like neutrophils increasing or decreasing means the patient have maybe viral infection or bone marrow suppression. If it's like lymphocytes the viral infection, if increased lymphocytes means viral infection, and TB, and another chronic leukemia can cause increased lymphocytes. Next, increased monocytes means chronic infections, tuberculosis, autoimmune. Increased eosinophils means allergy, asthma, and parasites. Next, we can see that is basophils like myeloproliferative disorders and allergy. Okay. In clinical application, we have some important things, that is always in anemia it will determine type of and severity, and infection means bacterial versus viral, it will give clue, and bleeding disorders means we can get thrombocytopenia, and inflammation and allergy means eosinophilia and basophilia, and we can see leukemia and bone marrow disorders like abnormal WBC or immature cells, and monitoring treatment and disease progression. Okay. Next, CBC pattern glands. If patient have iron deficiency anemia, the hemoglobin will reduce, the MCV will reduce, and the WBC will be like normal, the platelets will normal or it will increase. If B12 deficiency anemia means the MCV will increase, the WBC will be like normal or decreased, platelets will be like normal. So we have to suspect patient have macrocytic and hyperpigmented neutrophils. Next, acute bacterial infection. The WBC will be like normal, and the red blood cells will be like normal, the WBC will increase, and neutrophils will be increase. The platelets will be like normal. So you have to suspect neutrophilia or left shift. Next, we can see that is viral infection. In viral infection, the RBC will be like normal or it will reduce. The WBC will increase or normal. We call lymphocytes will increase. Next, platelets will be like normal or reduce. Next, we can see that is dengue fever. In dengue fever, the RBC will reduce or normal. The WBC will reduce. The platelets will reduce. So we can see leukopenia and thrombocytopenia. Next, idiopathic thrombocytic purpura. If patient have, the RBC will reduce like normal, the WBC will be like normal, the platelets will reduce. That is isolated thrombocytopenia. Next, always we have to follow some quality and pitfalls like hemolysis means falsely RBC will reduce, the potassium will increase. So we call that is pseudo hyperkalemia. Okay. And we can see that is clotting factor. The clotting will falsely means reduced platelets, we can see. Next, EDTA excess for RBC swelling, pseudo macrocytosis, the delay in analysis, that is cell swelling, WBC changes, and the platelet will get clumping. Always correlate with clinical findings whenever you are doing CBC interpretation. So at last, I want to tell you some things. Whenever you are doing CBC interpretation, first we have to check hemoglobin, anemia is there or not. Then after we have to correlate with MCV value, it's like macrocytic, normocytic, and macrocytic. Then after we have to check our WBC, if patient have any infections, a differential count of bacterial or viral. Then after we have to check platelets for we have to check bleeding risk. Then after we have to correlate clinically, never interpret alone of only CBC. Okay. So always, if you're a student, CBC is not just a collection of numbers. Each value tells you one story. So low hemoglobin tells us about anemia. So high neutrophil point toward bacterial infection. High lymphocytes suggest viral infection. Low platelets warn us about bleeding risk. The key to CBC interpretation is pattern recognition and clinical correlation. Master these patterns and you will be able to diagnose many diseases quickly and confidently. So thank you for watching. See you in our next section of video.